everybody, welcome to OsteoBites and thank you for joining us today. My name is Christina Iptoma and I am mom to Osteo Angel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. José Granados and Dr. Rachel Allavena from the University of Queensland School of Veterinary Science, and they will discuss exploring novel immunotherapies for canine osteosarcoma. Thank you so much, Dr. Granados and Professor Allavena, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelist, Samantha, for joining us. And everyone, please feel free to submit questions during the presentation through the Q&A. We will watch for those and we will share those with Dr. Granados and Professor Allavena. A little bit more about our guest today before we get started. Dr. José Granados is a graduate of the National University of Colombia and initially pursued small animal surgery before transitioning into roles as an educator and researcher. His academic journey led him to Spain and Germany, where he focused on feline and canine mammary cancer research during his master's and doctoral studies. And now based in Australia at the University of Queensland, Dr. Granados serves as a small animal surgeon, educator, and researcher, collaborating with Professor Allavena on pioneering immunotherapeutic trials for osteosarcoma and other cancers in dogs. He remains dedicated to making impactful contributions to the field with a steadfast commitment to continuous learning and improvement. And Professor Rachel Allavena is a deputy head of the School of Veterinary Science at the University of Queensland. She teaches toxicology, pathology, animal welfare, and laboratory animal science to science and veterinary students. And she is a specialist veterinary anatomic pathologist and is board certified by the American College of Veterinary Pathologists. Her research interests focus on translational and comparative medicine, principally on pet dogs with natural cancer, and as a translational model for oncology research. And she presented on that topic on a TEDx talk, which I'm excited to actually look for and watch. Her canine trials have been focused on bone cancer, melanoma, lymphoma, and mastocytoma. And her research includes biomedical device development, koala conservation, racing animal welfare, and production animal disease and economics. Since commencing her academic career in 2011, she has received nearly 14 million Australian dollars of grant and contract funding for research, published over 60 peer-reviewed journal articles, and has won several teaching awards, including UQ Citation for Outstanding Contribution to Student Learning in 2021. So we are so pleased to have both of you today. We're for sure going to learn a lot, and also just have to give you extra thanks for joining us, because I know it's extraordinarily early, your local time. So thank you both for joining us. And just a couple of announcements before we get started. First, I just wanted to highlight a resource that we have on the MIB Agents website that might be of particular interest to our audience today. We have a canine trials directory that lists some resources about canine clinical trials, including a list of veterinary oncology programs so that caregivers can find programs near them, as well as a list of canine trials. And in fact, the trial that we're going to be discussing today is on that list. And if you're at an academic institution that would like to be included, just email me at christina@mibagents.org. Also, I wanted to point out that our next tumor review board for osteosarcoma, which we affectionately call Turbo, is on July 10th. And the beauty of Turbo is that because it's virtual, we can include cases and attendees from all over the world, though it is at 5 p.m. Eastern, so there's a chance it could be in the middle of the night. But I think in Australia, it's a civilized 7 in the morning, so a little bit better than today. And while this is an educational forum to discuss clinical cases, research scientists and veterinary oncologists are welcome to join, as it provides insight into real-world clinical challenges. And if you'd like to be added to the calendar invite or are interested in presenting a case, just email me and I'll put more info about that in the chat. Lastly, we spent a whole episode last week talking about factor. So I promised myself I would exercise some restraint this week, but there is still time to register for our annual osteosarcoma conference. One update, our conference hotel is now sold out for rooms, but we will be adding rooms to a nearby hotel, so stay tuned for more info on that. And you can always email us at events@mibagents.org if you have any questions, and I'll put more info in the chat about factor. So Samantha, I would love it if you could please introduce yourself. And I also wanted to ask you, because you're going to be at Factor this year, and we do have a prom for the first time this year following our Friday dinner. So I wanted to know what you're wearing to prom, and what song are you requesting for the playlist that's going to get you out on the dance floor?
Okay, so my name is Samantha Ulloa. I'm 21. I was diagnosed with osteosarcoma in my right lower limb when I was 19 in August of 2022. I underwent treatment for about a year. And in November of 2022, I underwent limb salvage surgery. So I do have an internal prosthetic in my right leg. Um, Super excited for Factor, super excited for prom. See, I'm not sure. I'm between two dresses right now, but I'm thinking the color green. And then the song that I'm gonna have to request is obviously California Girls because I'm from California and I'm going all the way to Ohio. So super excited for everything. Yeah.
Representing. I'm from California too, so I'll be on the dance
Yeah.
floor. Okay.
Okay, cool.
Great. And then Dr. Granados, if you want to go ahead and start sharing your slides, I think we can go ahead and start
Absolutely.
the presentation.
Okay, can you see them now?
That looks perfect.
Perfect. Okay, so thank you very much for having us. We are really thrilled to be here sharing our work at the University of Queensland. We're going to basically talk about our clinical trial and the work that we're currently doing at the university with our canine patients with osteosarcoma. I have divided this presentation in three basic parts. So we're going to start with a basic intro about cancer in small animals and the similarities between human and canine osteosarcoma. Then we're going to delve into some more important details about understanding how tumors behave, their heterogeneity, how they interact in their tumor microenvironment, and also how they disseminate by means of circulating tumor cells. We're going to finalize this presentation talking a little bit more about our research and our canine osteosarcoma clinical trial. Our trial is a little bit on its infancy at this moment. So we're going to basically talk about our design, what are our objectives, our timeline, and what is the current status of our study and the status of our patients. So let's begin with the basic understanding of cancer in small animals. One important thing to consider here is that we love dogs, and dogs just play a very important part of our lives. They are everywhere. About 30 to 50% of the households in the planet actually own at least one dog. And unfortunately, cancer is very prevalent in dogs. It's very common. It's something that we see very often. It is estimated that at least one in three pet dogs will develop cancer in their lifetime. This is sort of discouraging and is an incidence that is much higher than that we observe in human patients. And it also means that as veterinarians, as dedicated people to the health of these animals, we are invested into identifying new therapies to help them and into find any possible way to treat our patients, as this is a problem that we deal with on a daily basis if we work with small animals. On top of that, these cancers are spontaneous, so dogs develop cancers on a natural way. We do not have to induce any sort of tumors as we typically have to do when we're working, for example, with mice or with other type of models. Dogs develop these tumors naturally, and they also share their same environment that we live in. They share the similar risk factors, and they're exposed to the similar things that might impact the development of these tumors, right? On top of that, our animals are just doing their normal thing. They're like living their normal lives. They have a normal immune system. They're not immunocompromised animals. They are healthy animals that happen to develop cancer, as it happens to humans. So it's very, very similar to what we see in human cases. But it just happens more often. In the case of osteosarcoma, it is estimated to be at least 20 times more common in dogs than it is in humans. So there is a huge potential for us to leverage any insights that we might obtain from these animals and try to translate them and make them also useful for human cases. Moving a little bit more into detail and trying to find the similarities between human and canine osteosarcoma, there are several. There are also some subtle differences. For example, the age of our patients. We typically see this tumor in animals that are older. typically animals that are at least 6 years old to 9 years old. However, there is a second peak in the incidence, and we also have some subset of cases that are more younger animals that are at least 1 or 2 years old. So this is more similar to what we observe in humans, as unfortunately, this is a tumor that is more common in children and teenagers and young people. Regarding the anatomic location of the tumors is quite similar. It typically affects long bones, as is observed in humans. We have a very clear breed predisposition. This is a tumor that we see most of the time in giant breeds, medium-sized to giant breeds. So dogs like Great Danes or Greyhounds or Labradors or Rottweiler are more commonly affected. It's very, very weird to see a bone tumor in a small breed like a Chihuahua or something similar. So there's an important genetic component. In terms of the therapy, it is quite similar. We do basically the most common approach, which is surgery and chemotherapy. In some instances, radiotherapy is also an option. However, the main difference is that our goal is not necessarily to do a very aggressive treatment with chemotherapy that might completely remove the tumor. Our goal is to extend the life of animals, considering the life expectancy. So our protocols are less aggressive. Typically, we work with one single agent, and our objective is to keep the tumor under control, induce a remission, but without causing any important side effects for the animals, because they have such a short life expectancy that we don't want our animals to spend months under recovery and to suffer from all the side effects of the chemotherapy. So that's basically the main difference. Unfortunately, in both cases, these tumors tend to metastasize to the lungs. In dogs, it's very dramatic, as more than 90% of the cases will develop metastasis, will develop lung metastasis, and only about 10 to 50% of the total animals affected are actually alive 2 years after the diagnosis. So the prognosis is, in our case, unfortunately, very poor, and there's a very high, the likelihood for these animals to develop distant metastasis is so high that is something that we deal with on a daily basis. On top of that, it's not very common for us to perform metastasis resection because they typically develop multiple metastases over a very short amount of time. So surgically removing them is unfortunately not an option in veterinary medicine, or not something that we do pretty often, as they're typically multiple. They're not resectable in most cases, and they develop very, very fast. Also, probably considering the life expectancy of our animals, everything tends to happen at a different speed. So, considering all of these factors, there are a huge amount of cases. There is a lot of similarities in cancer biology, in genetics. These tumors behave the same, they develop the same, and these animals develop them spontaneously. So as I mentioned before, we do not need to create the tumor artificially. What we're trying to do is to help these animals and to find a way to treat them, because they are in desperate need of finding a therapy. In most cases, their owners, after the diagnosis, they're just facing a very difficult situation because the prognosis in dogs is actually very, very poor. And then that gives us an opportunity to advance any sort of therapeutic developments in these animals and try to translate them and see if they are also applicable for the human case. So this translational oncology concept, it moves in both directions. It's not only us generating information that might be valuable for human cases, it's also as vets using any sort of information and advances that are made in human medicine and try to translate them and understand if they are suitable and if they fit our context and our patients. But we definitely have a huge opportunity here, which is actually a spontaneous model, natural model, that is just a little bit overshadowed and that is not commonly used in research as such, but luckily this is changing recently and there is much more interest in this topic. Similar to human osteosarcoma, we have made little progress in improving the prognosis of these animals, of these patients within the last decades. So that's a commonality. The prognosis of our animals was very poor in the 70s and 60s. Most of the patients affected had a survival of about 4 months, 6 months with surgery. once chemotherapy became more common, then we were able to almost double the survival of our patients. And then now we have patients that typically are able to survive for about 10 months, 1 year. But we have made little progress on that within the last 2 decades. So we're still a little bit stuck in that mark. And it's very rare to have individuals that would survive more than a year or even 2 years. It's very, very unusual. Most of our patients will unfortunately pass after a year of the diagnosis, like in best cases. So there is an important need for finding new therapies. This is urgent. This is a thing that we really need to do. And we hope that everything that we can do to favor our patients will also be translatable and will also be able to help human patients. The first thing, so moving into the second part of our presentation, I just want for us to recapitulate and understand how tumors work on a basic level so that we know what are we dealing with, right? So the first thing to consider is that there is a lot of heterogeneity within the same tumor, but also when we compare different tumors. So even when we have the same type of tumor, even when we're talking about an osteosarcoma, and even when we look at this tumor under the microscope and it looks the same across different patients, there is such a there's such a variations and such an important heterogeneity in the molecular level at the cellular level. So we have several clones of cells that behave differently. It was traditionally believed that tumors were mostly very homogeneous and was just a crazy cell that just start proliferating and invading the body. But we now have refined our understanding of this, and we now know that there is some subtle differences and some important differences within the same tumor. So we're targeting an enemy that has multiple phases. And it means that most of these cells are not necessarily likely to react in the same way to the same therapy, which means that we need to develop therapies that are wide in spectrum and that can kill all of them and eliminate all of them. But we also need to refine our therapy for these specific cells that are hard to treat. If only a few of these cells will survive what we throw at them, there is always a potential for the tumor to regrow and to reappear in a different location or to spread. On top of that, then we have traditionally called this disease the one disease, but it's actually a very complex disease. It's actually a disease that has multiple phases. We have molecular subtypes, we have different cases. So even when we're talking about the same tumor, there's a slight difference within different patients. On top of that, we also traditionally thought that tumors were sort of isolated within the body and that they were just there growing and invading and destroying the body, but they do communicate. They have complex communication mechanisms with the rest of the body, which is what allows these tumors to survive. So they somehow need to influence their immediate microenvironment to be able to gather resources, to escape the immune surveillance, to just be not destroyed by the body. So there are complex interactions that we're still trying to understand. There is literature being published every day on this topic, and we're just trying to learn more and more and more about these complex interactions and this complex communication. So we need to stop probably looking at tumors as a foreign body in our body, but more as part of our body that is using our resources and somehow tricking our body to believe that it belongs to it and it is just a normal part of our body. That makes it challenging. That means that we're trying to treat something that actually sort of belongs to our body, but we don't want it there, right? The final part of this brief description of how tumors work is how they disseminate. So we call these cells circulating tumor cells. They're basically super spreader cells that tend to invade distant locations. In the case of osteosarcoma, they're typically disseminated through blood, and they're typically generate metastasis in the lungs. There are different ways of dissemination in different tumors. In osteosarcoma, this is the most typical. And if we think about it, we're no longer talking about a tumor. So these cells are probably a better target because they are no longer protected by the environment of the tumor and by the tumor itself. It's very hard, sort of, let's say, to penetrate osteosarcomas with our therapies, right? They have this complex, they're bony tumors, they have these complex microenvironments, and it's very hard to target them. But we might find a window with these cells because they're actually out of the tumor. However, this is challenging because it's also hard to localize these cells and to isolate them from the bloodstream. But let's say this might be a better suitable therapy or a better suitable therapeutic target to prevent the dissemination of the tumor. So part of our research is focused on targeting these cells, and rather than trying to target the tumor and control the tumor, because we're mostly removing the tumor and doing chemotherapy. So our objective is to prevent metastasis from happening. So this is one of the most important targets and what has also inspired us to design our immunotherapeutics. One thing that I forgot to mention, sorry, is that these cells might also be potentially useful to monitor disease progression. There's literally very few information about this. So is it possible to measure the amount of cells? And is this measurement, is this count of cells correlated with the prognosis of our patients? Might this be a way to monitor disease progression and to monitor what is happening with the body? The traditional therapeutic approach, as we have discussed, include basically these three tools. There is more than that, but it's in most cases a multimodal approach. So we're trying to target the tumor to use different sort of therapies. That's what we call slash burn and poison, which means we're throwing everything that we have to these tumors. We're doing surgery. In some cases, we do radiation. We're doing chemotherapy. And we're trying to kill all of these cells and to eliminate residual disease. But if you also think about it, none of these therapies has, unfortunately, the potential to produce a long-term protective effect, because none of them are actually trained in the body to recognize these neoplastic cells. It means that in some very unfortunate situations, we may have the same patients with the same susceptibility, which is still prone to develop a new tumor, right? The same tumor, a different tumor, we don't know. So that's a little bit of we're hopeful that our therapies are useful to control the tumor and might induce long-term remission, but there's always this shadow, right? There's always this idea that the tumor might regrow, because what we're doing is actually controlling the actual situation in the moment, but we're less likely to induce a long-term protective effect in our patients. Is there an option to do this? Is there an alternative to try to create some sort of long-term protective effect? The answer is probably in immunotherapeutics. The basic idea of immunotherapy is to activate the immune system to recognize and attack cancer cells. This is something that sort of happens naturally at some extent, but at some extent, the body is no longer able to control the growing of the tumors. And it's very hard to understand why. Why in some cases does the immune system has some effect, and why in some cases it's just not enough. Immunotherapy has several components. This is a very basic description, and probably the hardest to achieve is to identify a suitable antigen. An antigen is a protein or a component of the cells that we use as a flag to inform the immune system, hey, the tumor is here, it's growing here. But as we spoke before, there's so much heterogeneity and there's so many differences within tumors that it's hard to identify an antigen that would work across different patients and across the same cases, right? It's like trying to find a needle in a haystack. There's thousands of genes that might be potential targets, that might be potential therapeutic targets that might work as antigens for us or as targets for any sort of therapy. And then it's very hard to pick the one that would actually work in every single case. Considering this, we have moved to a broader approach, which I'm going to discuss once we move to our therapy, but it's just very challenging to really find the right antigen that would work in every single case. This idea is not new. Dr. William Coley, who's considered the father of the immunotherapy, he was a surgeon, a human surgeon, and he just realized that patients that experience severe infections while having osteosarcoma or other types of malignant sarcoma, they just show better outcomes. And in some cases, these patients go into remission without doing anything else. So these patients develop infections, and what he got from there is something is happening. Somehow this infection is activating the immune system, and is helping the body to recognize these tumor cells and to destroy them. So he started injecting his patients with bacteria and bacterial products, live or dead. And then he was able to achieve some amazing results. He was able to cure some patients and to induce and to keep this patient disease-free for decades. That's what we call these toxins. Unfortunately, at the time, there was a lot of skepticism, probably because our understanding of immunology was very poor. And there's also, at the same time, radiotherapy, radiation therapy, and chemotherapy became more common. So this sort of overshadowed his research, and unfortunately, it went into, it was just forgotten, right? Modern immunology has actually validated these principles and have demonstrated that this does make sense. And in some cases, cancers are sensitive to an enhanced immune response, which is actually the case of osteosarcoma. Current research has also identified what was described by Coley a long time ago, right? Which is that patients that experience wound infections or implant infections are their limb-sparing surgery, they do have a better survival. This has been reported in humans and dogs. However, there is not a systematic way to really assess this. This is mostly anecdotal. This is what happens in some cases, but we also don't want to design a study in which we generate an infection and see what happens if the patient shows a better survival. But it just contributes to the body of information that tells us there is a way to activate the immune system. If we find the right way to do this, we might have our best friend and we might just awake this police officer in our body that would help us keep things under control. There have been some further progress specifically in small animals and in the development of immunotherapy, which have provided us with hope and just inspiration to pursue this way and to go in more detail into this research. Some of this research has also been already translated into human medicine. For example, LMPTP, this peptide, which is currently approved for the as an adjuvant for the treatment of osteosarcoma in Europe. And there are some very exciting research happening right now in different universities around the planet. So this is all everybody combining their brainstorming and trying to find a way to achieve a better outcome for our patients. Now I'm going to move into the final part of this presentation, and I'm going to talk a little bit about our research. I joined Rachel's team 2 years ago. So there's a lot of this work that she has been doing for the last years, which is really, really impressive and which actually inspired me to join her and to try to work together to make this even bigger and better. It is really, really inspiring. These are some of the patients that Rachel has treated before I joined the team. Basically, the research of our group is trying to work on autologous vaccines. That's the initial approach, which is using the same cells of the tumor to develop a therapy. So we produce a tumor lysate in some cases, which is collecting a piece of the tumor, mixing it with our adjuvants, which contain bacteria, typically mycobacteria and plant extracts. And then we inject this mixture into the patient. It can be only the adjuvants injected into the tumor. For example, in the case of skin tumors or different tumors, I'm talking about several types of cancer that have been included into clinical trials with Rachel. And we have seen such a good response in some cases. In some cases, these animals have achieved remission, and about 20 to 30% of the patients receiving these therapies displayed a very positive outcome. Now we need to figure out why. What is this? What is behind these responder animals? How can we track back and see we have a therapy that actually works, but we need to see how is it working? Why is it working? What specifically is the whole mixture of the cells? Is there any specific antigens within this cocktail that is actually awakening the immune system? So our idea is to work from this great option to this great therapeutic alternative and move backwards to try to identify how is this working and which patients are actually more likely to develop a response to our therapy. This is just some clinical cases. This is the case of PP, a patient with a high-grade oral melanoma. So this is a tumor that is likely very hard to resect or unresectable, right? In the oral cavity of an animal. This animal was treated by Rachel with injections of complete Freund's adjuvant, which is a mixture of mycobacteria and emulsified tissues. So as you can see, the tumor just disappeared after the injection. Just some weeks after the injection, there was a complete remission, not only macroscopically, but also at the microscopic level. So this animal was actually cured with this approach. There is another case that I love from Rachel cases. This is Griffin. This dog was diagnosed with a skin tumor, which was quite malignant, a very poor prognosis. And this animal, the tumor was removed surgically. Unfortunately, at the time when the dog came back for suture removal, the tumor has just grown back again. There is an important consideration here because this dog shared its environment with a kid. And then the owner had to face a very hard decision because this dog needs a chemotherapy, but the chemotherapy might possess some risk for the kid. So we don't want the kid to get exposed to the chemical waste, to the toxic waste, to be in contact with the chemotherapeutics. And then these clients took the decision to not pursue a chemotherapy on their patient, which makes them a little bit hopeless at the point because what else can they do to save their beloved animal? Then Griffin joined Rachel's clinical trials, and then he was able to survive for about 4 more years in remission of the tumor after being given just very few weeks of survival with the actual diagnosis that it has. So these are just some examples to just showcase what we're doing or the potential of our therapy. So now our objective is to translate this therapy into osteosarcoma. I'm going to finalize this presentation by talking about our clinical trial in osteosarcoma. As I mentioned, this trial is still in its infancy. We have a picture of little Crumpet here, which is the first patient that has received this new formulation that we're working on. Crumpet was diagnosed 10 months ago, so we're very hopeful for her. She's doing great. She's doing fantastic. She just became 9 years old recently. It was a whole celebration for all of us. And then we're just very positively following up on her and all of her cases. Our trial has 2 different groups. Our idea is, as I mentioned before, first to target the tumor and then target the circulating tumor cells. So we have developed a similar approach using tissue lysates and mix them with our adjuvants for group 1. This is the treatment that Crumpet has received, right? The idea of this is to remove any cells that might remain in the body, right? We are working in getting our technology ready for starting group 2. So we're working on circulating tumor cells isolation. Our idea is to use these cells to generate cell cultures and then produce our vaccine using these cell cultures, hoping that they can induce an immune reaction that would target those cells that are still in the body and that might be responsible for future metastases. Group 2 has not started yet. We're only working in group 1 at this point. So our trial includes several components. We're collecting samples for RNA isolation and RNA sequencing. This is probably the most important part in terms of understanding what is happening behind at the molecular level and what is characterizing, what are the features of the patient that actually respond to our therapy. We also working on the cell of the circulating tumor cells isolation. This is something that needs to be validated. It needs to be a standard technique. We need to validate if it is actually feasible to isolate, count these cells, and see if they have some usefulness in monitoring disease progression, as I mentioned before. And we're basically going to compare the results of group 1 and group 2 with a retrospective control group, which has received a standard of care treatment. So our therapy is compatible with a standard of care treatment. Some of our patients have received chemotherapy, others have not, based on client decisions. Some of them have only received surgery. So whatever is considered as a standard of care treatment, which in our case is surgery and chemotherapy, is absolutely compatible with our immunotherapy and can be done at the same time. we're giving our animals 2 doses of the tumor-based vaccine very soon after diagnosis. So we typically wait until the animal has fully recovered from the surgical procedure to start the first doses. We're collecting blood samples during this time, and we give a second doses 3 weeks after the first one. And from there, we start following up these patients for up to 2 years. So we initially do a follow-up, a monthly follow-up. Then we move to once the animal reaches 6 months follow-up, then we start following them up every 3 months, and then every 6 months after the first year. This is our timeline. So this project started recently, like in June or July from 2023. So we have some patients that are, as I mentioned before, almost about a year, and we're still recruiting, actively recruiting patients and moving forward on our trial. The main goals is to compare if we actually achieve a reduction in metastasis rates in these patients between the 2 different groups compared to a retrospective control group. We want to also evaluate if this therapy actually increases or improves the survival of these animals, and investigate the potential of these circulating tumor cells, not only as a therapeutic target, but also as a way to monitor disease progression. The background of all of this and the way that we're gonna really understand what is happening at the molecular level is by using RNA sequencing. So comparing the gene expression patterns between different types of tumors and comparing and correlating this information with the animals that actually respond to our therapy. This is the list of our patients. We have recruited 5 patients so far. All of these patients are doing great. Unfortunately, we lost one of them. Luna developed a splenic hemangiosarcoma and intra-abdominal hemorrhage. So we lost her very, very soon after recruiting her. The rest of our patients, our remaining patients, are doing well and are being very closely monitored. So we're very hopeful about all of them, and we're very positive and actively recruiting more animals to increase our numbers. And that's the end of our presentation. So I would just like to thank to our beloved patients and their owners for giving us this opportunity to try to make a change and help them. And also to our beloved team, which is very supportive and very professional and have been like every step of the way with us. And of course, we would also like to thank our sponsors and donors, which play a very crucial role in making all of this possible. So thank you so much for your attention. And if you have any questions, we will be happy to answer them.
Thank you so much. That was wonderful. And also really enjoyed all the cute dog pictures that you had in all your slides. That always makes it more interesting. But everyone, please feel free, if you have any questions, to add them to the Q&A. And I have a couple questions about the trial and how the vaccines are administered. So you noted, like I know in one example, I think it was Griffin who didn't receive chemo, so received the vaccine after surgery and after had relapse. But you had mentioned that it could be given with chemo or after chemo. So I'm wondering kind of when is the best time, like when do you harvest the tissue and blood to create the vaccine, and how might giving chemo, if chemo is given, like do you harvest like post chemo or before chemo? And if post, like is there a chance that chemo can maybe kind of affect the antigens or?
Yeah. So Rachel, do you want to address this one or should I answer? I'm happy to answer.
In general, we get the tissue samples before the animals have chemo. So the surgeons like to go in and, you know, get what they can. And that's when we're taking our first round of research samples and what we need to actually make the vaccines. So with the models that I've been doing, we look at 2 different types of patients, and this is beyond osteosarcoma. So there's some dogs where we can't do surgery, we can't take the cancer out. So for that group of patients, we just inject the adjuvants directly into their cancers and then monitor them clinically. And that was a lot of the skin cancers you saw, like Griffin there, and Pippi with her oral melanoma. Those were non-resectable cancers. So we can just stick it in, and then sometimes we can actually take biopsies or do curative intent surgery. Then that's what we're trying to do with the osteosarcoma. Take the tumor out of the animal and then make a vaccine. And once we emulsify the vaccine, we can inject it back in like a dog's getting its regular puppy vaccinations. So we're always trying to get the tumor tissue before they have chemo. And then generally we wait a few weeks just to allow, especially after an amputation, it's such a big surgery, wait a few weeks for the animal to be able to heal and see what it's doing. And then the chemotherapy starts usually after 2 weeks. So that's about the amount of time it takes for us to do the diagnosis. So as a pathologist, I'm doing the diagnosis. I'm looking at the tumor grades and the tumor types. And it's also about the amount of time we need to manufacture the vaccines and get them going. So around the time when the chemo starts, if that's what the owner wants to do, is when we would start doing the immunotherapy treatment. Unless they're one of the ones where we're just sticking it right in there. In that case, we just go straight for it as fast as possible, try and get it under control. So yeah, we have 2 different approaches, which is a bit confusing to people that we have intratumoral, but for osteosarcoma, because the animals absolutely need to have the amputations, we just use a vaccine. So we just use a resection and vaccine model.
Right. So just to make sure I understand, so you usually are resecting so that you do have tumor tissue to work with and creating the vaccine from there, but it is pre-treatment. And you said, how long does it take about?
They can run in parallel. So we don't ever want to stop, I guess, same in human medicine, an animal having a standard of care approach when the owner can afford it and that's what they want to do. That wouldn't really be ethical for us to do experimental therapy when and deny the patient the opportunity for standard of care. So we're usually doing them together. And you're absolutely right. I mean, there's a concern that the chemotherapy can immunosuppress the patient. But prior to us working on bone cancer, we were working on a number of cancers where the animals might need corticosteroids to make them more comfortable, and they still seem to have reasonable responses. So I think it's just a question of we have to give it a go. But as Jose was saying earlier in his talk, our goal with veterinary medicine is always to keep our patients comfortable because they can't give us informed consent. Their owners are acting on their behalf. So we're always trying to minimize the side effects, make sure the animal's welfare is paramount. And if that's traded off against more time with the owner and the animal surviving longer, we will do that. So for us, it's more quality of life than quantity of life in the veterinary patient. So if they need chemo or they need corticosteroids and that's the best thing for them, we will keep that going in parallel with the immunotherapy. Do you think that's fair, Jose?
Absolutely. I totally agree. Yeah.
Okay, so we do have another question. It says, why pay the trial for osteosarcoma dogs and need IND or not?
IND. So for IND, for me, is an investigational new drug file. Okay. No, we're a long way from that at the moment. And we're still actively working on the formulation. So, Colles toxins is a very old technology, as it's more than 100 years old. And when we initially started, we started using a reagent called complete Freund's adjuvant, which Jose mentioned, and it's just dead microbacteria in oil. And it's been around since the 50s. So it's not patentable. It's a research reagent, and it's a very, very potent adjuvant. It's probably one of the nastiest ones. But we figured if we were going to tackle something like cancer, we really needed something very potent. So we're moving from the complete Freund's adjuvant, which we know works and is really, really strong, and therefore might have some side effects, which, of course, as I said, in veterinary medicine, we were always trying to really manage and minimize those, to maybe taking components out of that, different types of mycobacterial proteins and mycobacterial lipid coat, other adjuvants that we can mix in together to get a synergistic effect without driving the animal into negative side effects. And we're actively working on trying to make the recipes better. And if if we get that far, it might end up as something, you know, that would be the dream, right? To have something that might go down the pathway of regulatory approval and an IND. But at the moment, we're just operating in like research mode. And for that, in Australia, we have animal ethics approval. It's conferred and independently reviewed by our institution. That allows us to work with the pets. And then obviously, when we're working with the pets, we're getting owner-informed consent and making sure they're comfortable with everything in the trial. So that's how we're working at the moment.
Okay, there's another question that says, as you mentioned, when tumor is non-resectable and inject adjuvant, has this adjuvant been used alone as a non-specific immunostimulant to show it doesn't have any activity alone? As in like not needing autologous component?
That's a really interesting question. There is actually a company and some research that shows that if you do infusions of mycobacterial components, it can be useful in palliative therapy for dogs. It can just improve their well-being and their demeanor. And that's not targeted specifically at a tumor. It's just an infusion, as far as I understand. It's not something that I've worked with, but it's technology that I've heard about. So there is a chance that even though we're very convinced that when we start to put these potent immunostimulants into tumors, that we're directly targeting an immune response and generating an immune response, because we see histologically when I look at the tumors, the immune cells are not there, and then they start to come in, and then there's all these complex interactions which we'd love to understand more about, and then the tumors disappear. And they're typically disappearing at about week 5 to week 9, which is very interestingly exactly the window of remissions that Coley noticed, 100 years ago. There's something that happens in that magic window for the patients that are going to respond. So we're pretty convinced that when we're doing these things, we're driving a specific autologous immune response. But there is probably good evidence from other literature and other drug development that just these components in and of themselves can have some sort of beneficial holistic impact on the patient to make the patient feel better or to improve their well-being. So that's one of our most difficult things to figure out, especially with osteosarcoma. So when I was working with the other tumors, is we could go in and we could take pieces of those tumors over time, especially if they were non-resectable from the dogs, and then use technology like just general pathology, immunohistochemistry, RNA sequencing, to look at those immune responses in the tumor. But with osteosarcoma, the animals had the amputation, so the primary tumor's gone. We can do limb salvage in dogs, but most owners won't opt for that. But there's just nothing there for us to then assess immunologically, and we can't really access the chest cavity easily in dogs. It would be difficult with what we can do for their anesthesia and their pain management, to do thoracotomies or to do sampling from the chest. Plus, we have some ethical concerns about that. So that's where Jose's really driven to start looking at the circulating tumor cells and the blood responses. And that's where we have to go in osteosarcoma. That's why it's not only is it a cancer that's of great unmet medical need, but it's actually the most technical one we've worked with, because we're not able to just go in and resample it and have a look at the immune system. We're going to have to use surrogates. We're going to have to use the circulating tumor cells and the blood cytokines and the other things in the patient to understand if, how are we getting a very specific immune response? Is it targeting the osteosarcoma? Is it a more holistic improvement in the animal's immune function that's benefiting it? And that's absolutely a fantastic question. It's also very expensive science to figure that out in dogs. So that's hopefully where we'll go in the very near future. Jose, did you want to elaborate on your dreams, the CTC dream?
Yeah, absolutely. So the idea is to refine this therapy further, right? And to be able to target more specific components that are involved in the tumor dissemination. This requires a high level of technology. This requires a lot of investment into achieving this. So our initial model is a little bit quite simple, right? It's a little bit more easier to produce. And then this is gonna first allow us to verify if this, I mean, we have actually achieved safety demonstration with these formulations in the past in different tumors, but we're now evaluating what is the situation with canine osteosarcoma. Does this induce any undesirable side effects? Is this safe for our patient? Are we seeing any positive response? And then our objective is to move forward and refine this therapy to actually target these circulating tumor cells. So it's all very exciting. We're working on a daily basis just to ensure that we can move forward with the project and that we can actually, do some exciting developments and work in something that can actually benefit our patients. So until now, we're very happy with what we have been doing. Our patient seems to be doing great. We have literally very, very minimal side effects. Our clients are also happy with the therapy because it's not a therapy that is invasive or that would in any way like alter the quality of life of our patients, which as we have discussed or mentioned several times is paramount and super important for us and for our clients. So yeah, it's a very exciting research, and then we just hope that we have the means and the patients available to move forward.
I love that you have CTC dreams.
I have CTC dreams every night.
You had a
Constantly.
got a vision. Maybe a vision's a better word.
You know, I'm actually curious when you brought that up. So I know in some of the other, like with MTPPE, for example, it's common for the patient to have, you know, right after administration, kind of a little bit of a reaction, you know, that's managed through pre-medication. And is it like that in the canine patients when they get the vaccine? Is there, you know, a short-term immune response to that where they
yeah, exactly. So we want to see a bit of a reaction because that somehow means that the immune system is doing something. So we expect to have the normal things that can happen after any sort of vaccination, which is maybe a little bit of lethargy, fever, maybe a little bit of local pain at the injection site. In some cases, we had patients that develop sort of a small lump at the injection site. And up to now, we're understanding this as something positive because it might mean that the patient is developing sort of immune reaction. But we still need the numbers and the data to see if patients that actually show this sort of light side effects during the immediately after the injection of the vaccine might do better in the future. So we still have only 5 patients in this group. All of them have actually displayed at some level this discomfort or a little bit of lethargy or a little bit of pain at the injection site. This typically subsides within the next couple of days. It's not a long-term side effect. It's typically 2 days, tops 3 days in most cases, and it doesn't require any additional treatment. It doesn't require anti-inflammatories. It doesn't require anything else. The animals are still eating, drinking, and happy. They're just a little bit under the weather, as happened with all of us after receiving any sort of vaccination. But this might be actually positive. We just need to really correlate these findings with the outcome of our patients.
And if anyone and the listeners are very familiar with William Kohler, he used to really deliberately induce a lot of fevers. He used to push his immunotherapy very hard. So frequent dosing, making the patients febrile, and he thought that was really important for the mechanism to work. But actually, we don't do that. We don't. It's very infrequent dosing, every couple of weeks to months, depending on the protocols. And we definitely don't make the dogs feel sick, and it still seems to work anyway. So that's a really good thing.
One thing that you had also talked about was the tumor heterogeneity. Oh,
yes.
Sorry, but I just butchered that word. And I'm curious, given that challenge when you're creating an autologous vaccine, how do you know that you're kind of getting like all the representative antigen whatever sample, just because that seems to be a challenge. You have intratumoral heterogeneity and
Yeah, it is. It is actually. Sorry, were you saying, Rachel?
No, I was just saying, well, as a pathologist, all I do is I look at the tissue and, these concepts, so that little cuttings, we see it. You can see the clones. You can see the clones that look nasty. You can see the clones that look less nasty. So it's in there. I mean, the amount of tissue that we need to make the vaccines is, it's not that, it's like a little sugar cube, it's not a huge amount, but there is a lot of tumor in there, I guess, in terms of antigens. But what we've deliberately tried not to do is think for the tumor, to say, oh, we're going to go after this target, or we're going to go after this peptide, or this specific thing. Our therapies are also like almost crude in that people will ask me, well, what do you think the target is? And I'm like, I don't care. I don't care. It's not really up to us as scientists to pick the target. That's a dialogue between the immune system and the cancer, and it's going to be different for every patient. So we select a relatively large amount of tumor, or when we do the intratumoral injections in the other model, we are just putting the danger signal straight into the mass. And then it's up to the body to decide what the best antigens are. So we've deliberately sort of moved away from that. But I guess, even a sugar cube size of cancer has actually got a lot of different proteins in it. Jose, sorry, did you want to?
Absolutely. No, I was just gonna say the same. So it's very hard. And as I mentioned before, it's like trying to find a needle in a haystack. It's very hard to really go and randomly pick a target, just because this target seems to be common and seems to be present in different tumors. We wish we could move towards a more targeted approach where we can actually validate, like as scientists, yes, this is the target that is important. This is what is making the therapy work, but maybe that just doesn't exist. Maybe it's just not this magic target that would cure every single patient. So I agree with Rachel, is more of a bigger and complex dialogue between the tumor and the immune system. And also when you're designing different types of therapy, not only immunotherapy, it's also very hard to find a target that would actually at some point kill the entire cell and make the tumor just crumble and disappear. It's very, very hard. I hope that there is such a thing as a specific target that would immediately, once attack, disintegrate the tumor and not get it to grow anymore. But I feel there's so many possible targets that is very random to decide which one should we pursue. So we have moved to a different approach, which is having a therapy that actually shows some response, right? That when we consider animals are getting better and improving, and when we are inducing remission, and then work it backwards and then figure out how is this happening? Is this actually a target, or is this more of a complex dialogue between exposing the immune system to the entire tumor, to the whole proteins of the tumors, and how is this working, right? So there's a need to really understanding how is this working, but it's not necessarily by targeting one single specific molecular target in particular. So our vaccines are tailored for each specific patient because they are produced with the tumor from each patient. In that sense, it's a very individualized therapy, but it's not necessarily aiming to identify any single specific target that we believe might be the secret for this recipe, right?
Got it. And you know how you had the two, there's the group 1 and the group 2, and I think group 1 was based on the tumor tissue, and group 2 was based on the CTCs. And I mean, it sounds like you're doing kind of both and you're going to maybe compare them, but I was wondering, like, does it make sense at all? Or are you looking at doing them sequentially? Does that make sense? Would that make sense at all to kind of administer a vaccine based on the tumor tissue and one that was created based on
for the same dog?
Yeah.
Well, yeah, I think so. I think we've got a lot of technical hurdles to get those CTCs under control. And I think it would. And actually, one of our visions, if I'm not going to use dream anymore, one of our dreams is that we can move from the individual patient to have like maybe a cell culture based on the CTC. So then we can have vaccine ready to send out to patients as soon as they get diagnosed, and maybe start the immunotherapy as soon as possible while they're going through their surgery and everything, just to try and to instead of having to wait that 2 weeks, to have something just straight away that we can get in there and hopefully improve their clinical responses.
Great. I know we're almost out of time, but there was another question that came through that it's kind of a more general question, but maybe you can just kind of speak to it. I think the question was more about kind of backing up a little bit, not super specific to this trial, but just like how this is probably not a 1-minute question, but just how a drug kind of gets into a canine clinical trial. Like at what point does, are you able to kind of start a trial with a perspective?
Well, as I said, human medicine informs veterinary medicine, and we're hoping to push a little bit back and get it the other way. But when good candidates are identified, researchers and drug companies can file the necessary ethics to start their trials. And in veterinary medicine, because we have so many species and you can't test in every species, like say maybe your giraffe gets sick or your elephant gets sick, how are you going to know? No one's done a clinical trial on those. We actually use a lot of off-label therapy legally. The veterinarians, especially in Australia, have the rights to talk to the owner and get consent and then progress off-label therapy. So sometimes drugs are used under off-label.
Thank you. Thank you for a comprehensive but succinct answer to that. So that went by so quickly. Thank you so much for joining us, Dr. Granados and Professor Allavena, for joining us on OsteoBites today and making it better for both our 4- and 2-leg osteosarcoma patients. Though I should say sometimes there are actually also 3- and 1-leg in osteosarcoma.
Yeah.
So anything under 4. So more information on this and all OsteoBites can be found on the MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And we hope you can join us next week on OsteoBites. We're going to be joined by Dr. Troy McEachron from the National Cancer Institute. And his laboratories focus on understanding the oncogenic and immunoregulatory mechanisms within the metastatic osteosarcoma microenvironment and how they impact therapeutic efficacy. So a really nice follow-on to the discussion today. And he's going to be talking about his lab's current work in using various omic technologies to deconstruct metastatic osteosarcoma. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for future topics you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Granados, Dr. Allavena. I think it's maybe time for some more coffee and breakfast for both of you. But thank you so much for making the effort to join us today. And we hope to see you back here. And maybe, you guys can also catch it on demand, our episode with Dr. McEachron next week, when he's going to be talking about the molecular and cellular deconstruction of metastatic osteosarcoma. Thank you so much for joining us today. Thank you also, Sammy, for joining us. It's great having you, and we hope to see you next week.